And good evening to everyone. I would like to welcome you to this third fireside chat of the ACS Academy of Master Surgeon Educators. I'm Ajit Sachdeva. I'm the Director of the Division of Education at the college, and I also have the privilege of serving as co-chair of the steering committee of the Academy along with Dr. L.D. Brett. As some of you know, we appointed a special committee of the Academy almost a year ago at the beginning of the COVID-19 pandemic to do a survey, to scan the horizon, and to determine the needs in residency training during the pandemic. And lo and behold, that committee has done a phenomenal job in pursuing many different and new programs. We've had several subcommittees working on various projects, and one of the subcommittees is the subcommittee on novel teaching methods. And although that subcommittee has been focusing on the pandemic, clearly many of the things that have come out of the subcommittee and the committee as a whole will endure for years after the pandemic is behind us. That subcommittee is chaired by Dr. Mohsen Shabahang, who is the chair of the Geisinger Surgery Institute, who's been the organizer of these fireside chats as well as the Grand Rounds series that has been started. And this evening, we are absolutely thrilled and honored to have with us as our fireside speaker, Dr. Carol Scott Connor, who is a distinguished member of the Academy herself. And Mo is going to formally introduce Dr. Scott Connor to the group assembled here this evening. And before I turn over the floor or the virtual floor to him, I'd like to thank the staff for helping with this program and for organizing this evening, and recognize Dr. Lisa Nagler, who's our Assistant Director in charge of the Academy, Ms. Susan Newman, who is the manager of that area, again, a household name again, much like Elisa's name is a household name in the Academy circles, and Diamond Lanier, who is working as an administrator in that same section. So with that, thank you all for joining us. We look forward to a very exciting dialogue, and I'll turn it over to Dr. Shabahang. Thanks.
Shiva, thank you so much, and thank you all the participants who are joining us. Just a couple of house rules. This is a regular Zoom link, so please feel free to put questions and comments in the chat box. We really enjoy that, and we're going to kind of monitor that. And I may even call on you to ask your own question, but please use the chat function as much as possible. The other house rule is that obviously please do mute your devices. We would love to see you, so please feel free to turn on your video. We would love to see you and for this to be an interactive and quaint gathering. With that said, as Dr. Sachdeva said, we have really been excited about the Fireside Chat series. The purpose of this is really to have an expert in surgery and surgical education interface with our membership. So I've had a pre-chat with Dr. Scott Connor, and I think we're in for a treat tonight. I very much enjoyed it, and Carol, really thank you so much for spending the time with us and sharing from your experiences with us and our participants and guests tonight. So when we talked, I mentioned that I usually like to ask you to introduce us to your career path and some of the highlights that you think are worth mentioning. So I'm gonna yield to you and let you talk to us a little bit about the highlights of your career.
Thank you. I want to thank you for giving me this opportunity to talk with you. And I want to tell everybody that's here that I see a lot of familiar faces and names. And I thank you for joining us. And I hope you will put questions into the chat. We already have one question, and we're looking for more. I will take you back to the 1960s. That's when I was in high school. And I want you to understand that it was a very different time then. There were a lot of schools that did not admit women. There were a lot of schools that admitted women that had quotas. And when I went to MIT, which was one of the schools that did admit women, it was the height of the Vietnam War. So when I got ready to go to medical school, I would find myself asked by admissions committee members, why should we admit you? You're a woman. You're just going to get pregnant and drop out. And you'll take the place of a man who could get a deferment. You could get a draft deferment. A lot of people don't even know what the draft was about now, which is a good thing, but you could get a draft deferment. And if that man ends up in Vietnam, he could come back in a body bag. And this was a perfectly legitimate question to ask and almost an unanswerable one. So my career, and particularly the early part of it, was shaped by the necessity to look for doors that were open, to walk around doors that were closed, and to find ways around obstacles. And I have benefited by the help of a tremendous number of wonderful mentors along the way. And we'll talk about mentorship later in the hour, I hope. But let me tell you a little bit about my early days in surgery. I went to NYU Medical School, and I fell in love with surgery during my clerkship in Bellevue. And it was just phenomenal. It was amazing. And I wanted to stay at NYU. That's where I wanted to do my residency. And in fact, I did match at NYU. And one of the reasons I wanted to match there was that there was this sense of pride at NYU. And I think it was true, the sense that you were prepared to deal with anything. And I wanted to be able to deal with anything. I was very much taken with general surgery, and I've remained taken with it all my life. But the interesting thing about NYU, and here's the point of this story, there were two things that you didn't do if you did your surgical residency at NYU. NYU is not yet doing renal transplants. Well, I could live without doing renal transplants. But NYU was not taking care of burn patients. The burns went to the burn center, which I believe was at Cornell. And so I thought it was sort of a shame that I wouldn't get any training in how to take care of burn patients. So I arranged to do a fourth-year clerkship as a medical student at the Shriners Burn Center in Boston. And it was wonderful. I was the only medical student on the service. Anybody who has ever scrubbed on burn cases knows that there's a lot of work for everybody. I got facile at excision and grafting, and I had all this kind of knowledge about wound management that I put away in the back of my head and then didn't use for the entirety of my surgical residency. I finished my surgical residency and I took my first academic job at a small new medical school, Marshall University College of Medicine in Huntington, West Virginia. And at that time, my main interest was benign GI surgery. I loved big, open abdominal surgery. I loved ulcer surgery. I loved open biliary tract surgery. And that was what I hoped to concentrate in. There really weren't fellowships at that time, or if there were, I wasn't aware of them. So I just went out and said, this is what I want to concentrate in. Well, I was the junior faculty member of a 3-person full-time general surgery group, and I was doing a lot of surgery, and it was great. And then about a year into my time there, as I recall, one of my senior partners announced that one of the hospitals where we worked was going to open a burn unit, the first burn unit in the state of West Virginia. And oh, by the way, Carol, you're going to help staff the burn unit. I'm like, I didn't do any burn surgery during residency. Well, of course, I had a little bit to fall back on. When you're junior faculty in that kind of situation, at least in that time, you didn't say no. It was kind of like, you want me to jump? Okay, how far? Well, I started taking care of burn patients, among other things. I took my burn rotation. I learned from my senior partner. I built on what I had learned at Shriner's Burns, and it turned into a major interest that was sort of an academic interest that persisted for years. And so this little opportunity, this challenge, and that's why, Mo, I think you made a reference to my saying during the Olga Yonason lecture, you know, say yes, time is elastic. My inability to set bounds and say, no, I'm not going to do burns. I want to be a GI surgeon, led to an unfolding of a whole new area that I would not have seen. Now, as it happens, as you all know, peptic ulcer disease went the way of the dodo. The only peptic ulcer disease we now do is for complications of neglected ulcer disease. Peptic ulcer disease is a medical disease, and that's much better all around. But the things that I love to do, you know, highly selective vagotomy and pyloroplasty and antrectomy and vagotomy, all this stuff gone. Then open biliary tract disease. What happened? Lap coli. And it came out just when I was, you know, you get to this point when you're about 10 years out or so, you think you're really hot stuff. You know how to operate. You're good at what you do. You like what you do. Nice, smooth path. Something comes along that's a major disruptor. And for me, it was lap coli. And it turned into a major opportunity. We were faced at the national level, and I say we in academic surgery, with the issue of training all the surgeons that were doing open biliary tract surgery in how to do lap coli. So SAGES was the organization that stepped up to the plate for that one and formed a group called Train the Trainers, where we were sent around the country, groups of us, and I was one of those that went out around the country to teach other academic surgeons how to do lap coli so that they could then teach their residents. And you know the rest of the story. The whole field has blossomed unbelievably. That was a major disruption. And you know, there were surgeons who were near retirement when lap coli came out who decided to retire instead, or who never learned how to do it. I'm telling you this story, which I think is a familiar story to all of you, even if you didn't live through it, because that was a major disruptor. But a major disruptor can be a huge opportunity if you're willing to take the opportunity to learn a new skill. When I came to the University of Iowa in 1995, I was given the job, I came as department head, and I was given the job of making the University of Iowa a level 1 trauma center. And it was a wonderful job. I loved having that job because it was a doable job. It was a job that needed to be done. And I thought we could do it. But what I had to do, it was very hard to recruit people to come and do trauma, you know, right out of trauma fellowships, because we didn't have a big volume. So those of us that knew enough about trauma, we took trauma call. Now, I didn't really want to take trauma call at that point in my life, even though I had a really good background from Bellevue, but I did. Now, here's the point of this story. By taking trauma call, I learned how to do FAST exams, focused abdominal sonography for trauma. And that gave me a leg up when I wanted to become ultrasound certified to do breast ultrasound. I was already comfortable with the technology. And that challenge of taking trauma call became an opportunity that helped me build my skill set. And 2 surgical organizations stepped into the breach there too. First of all, the American College of Surgeons gave a basic ultrasound course that you could do offline. And I did that. I got the basic ultrasound course certification. And then the American Society of Breast Surgeons gave a breast ultrasound course that the prerequisite was the basic ultrasound course. And I took that, and through them I got certification, which was at that time important for what we were doing. You know, I talked this over with a classmate of mine in the writing program that I'm currently in grad school. And she pointed out that she had been to a talk where someone said that whereas many years ago people might expect to stay in one career for their entire lifetime, we're not talking about doctors, we're just talking about people in general in the United States. She said that now people will change on an average 3 to 4 times over the course of a lifetime. And I have been telling our trainees for quite a few years now that I think they will be reinventing themselves multiple times over the course of their lifetime. So that's a nutshell. I think that having had in the beginning of my career to look for the doors that were open, trained me to view challenges as open doors through which I could walk to a new opportunity.
Carol, this is wonderful. And when we talked about, I think I wrote down the word, the transiency of our careers, and you've alluded to that in several parts. And you also pursued a PhD in anatomy and cell biology, an MBA. You went from being a GI surgeon to a breast surgeon. How does one not view these disruptions as an adversity, and how do we overcome them? How have you overcome them? How have you reinvented yourself? And I know you've alluded to it, but in the advice that you give to mentees, what is the advice you give?
I think first of all, you have to be mentally prepared for the likelihood that at least every 10 years, you're going to find you're doing new operations. I mean, I think of all the vascular surgeons who were very facile in open vascular surgery, and then endovascular techniques came out. It's a better way of doing a lot of things. Think about heart surgery, coronary bypass grafts with big sternotomy. A stent's a lot easier. So you have to be prepared for it, and you have to be kind of looking at the horizon. I've always maintained a 5-year horizon, and I've had people say that doesn't work. You have to have a longer horizon, but I swear I can't figure things out more than about 5 years in advance. And even then, you know, who could have seen the pandemic coming? We might have seen that something like this could happen someday, but that it would happen and so suddenly and affect all of us. But I think you can maintain a 5-year horizon. I was doing predominantly breast surgery when I retired 5 years ago. And so I would ask you, Mo, do you think 10 years from now we're going to be doing breast surgery the way we do it now?
Absolutely not.
I mean,
that's changed.
You know, it's changed so much.
Exactly.
Think about sentinel lymph node biopsy. Think about the fact that we now biopsy with a needle rather than with a surgical incision. It's better for the patient. It's better all around. Think about neoadjuvant chemotherapy. Is the day far off when if we get a complete imaging response, we can maybe do biopsies and not do surgery and assume that we have a complete pathological response? I don't know. But the field has changed so much and will change so much. So suppose you're a breast surgeon. I'm not saying don't go into breast surgery. I'm just saying be prepared to change. And change could mean doing less surgery and more office-based procedures, and staying with the concept of the care of the patient with breast problems. Or it could mean switching to a different type of surgery if you like the surgical aspect. But keep that 5-year horizon is my advice.
So Carol, you know, you've talked about how you've viewed this and change, but you are also a department chair. And, you know, I know one of the challenges many of us face is when you say to a young surgeon, be open to new things, and maybe you want to go and learn how to do robotic surgery or something of that sort. There's a resistance to that. How did you deal with it as a department chair, and how would you advise a younger surgeon right now who is resistant to that, who sees the end of their training as well? I'm done training, I want to be practicing right now.
So I'll tell you a story. When I was department head, we got a robot. And with the robot came X number of slots for people to go out of town to get training. And at the last minute, one of the surgeons who was supposed to go from my department had to cancel. And I was determined that this slot was not going to get wasted. It was literally a case of, are you willing to pack your bags and go tomorrow because they're having training? And one of the pediatric surgeons took the training, wasn't planning to take the training. I wouldn't probably have thought to send a pediatric surgeon because the robot is this huge hulking thing, you know, little bitty baby. I couldn't visualize it. But he was willing to go the next day. I seem to recall it was like the next day. He went, he jumped on the plane and he went. And he came back and he started doing all kinds of wonderful things. And it became a major focus of his clinical activity. He took the leap of faith. It's a leap of faith that you have to be willing to take. And some people will take it and some won't. Some want, I think some people want their career to unfold step by step in a nice logical fashion. Okay, I'm going to do my fellowship. I'm going to do this. My practice is going to be limited to X. And that's going to be the rest of my life. And I think that's just unrealistic. The reason I told you about my experience with burn surgery and my experience with lap chole and the experience I had with the surgeon who went and got training for robotics is you don't know what the future is going to dish out. And the more training you get, the better. You can always pare it down. You know, if you are so busy that you just can't handle it all and you're clinically overwhelmed, then hopefully you can go to your chairman and make an argument that you need to be able to focus. And then you go with a plan and you say, I want to focus on this. This will allow me to do such and such. And here's a plan for how these other patients could be taken care of. I'm not saying be a rug on the floor that everybody walks on. I'm saying that these are opportunities.
And it's interesting, I'm looking at the comments from Elliot Goodman, a third-year medical student, who says, you know, I think you've already affected one medical student who says, I'm learning today, what I'm learning today might be outdated just 10 years from now. There was a point that you made that I don't want I would like to just focus on that a little bit more, both in terms of mentorship that I know has been important to you, and also this concept that you said in the talk you gave in 2019 that don't worry that much about drawing boundaries, and you just said, you know, I'm not saying be a rug, and that the comment that people make is, what about my time? I don't have time. And you said time is elastic. Can you elaborate on that and also on the concept of mentorship?
Yeah, I can. I think that we have much more time than we think we do. I think that when I think back on how I use time, and I don't hold myself up as a paradigm, I spend a lot of time goofing off. I spend a lot of time reading science fiction novels or watching Star Trek. But if I was waiting for a case to start in the evening, I'd work on a manuscript. Back in the day, before we had laptop computers or iPads or iPhones that you could just take everywhere and work on stuff anywhere you were, I always had a folder of stuff that I could just take with me. And people actually commented on that. if you wait for there to be a block of time to do something, that block of time may never come. But if you can train yourself to do things in little bits, and I'm talking particularly about academic things like writing papers or writing grants, then you can get a lot done. The other thing that I did throughout my career, and I'm going to tell you the truth, but a lot of people think I'm crazy, but I'm telling you, this really works. This is a good thing. This really works. Most of us have more vacation time every year than we use. You can take some of that vacation time and go to the library and work on a manuscript. We used to do our vacations in Woods Hole, which is a marine biological laboratory, has a wonderful library. And we would spend the mornings in the library. And it was out of necessity because my husband's a fair-skinned redhead and he didn't want to get skin cancer. So he wouldn't go outside. So there I was trapped in the library on vacation days until afternoon. And I just got in the habit of doing my writing then. And it was wonderful. So there is time that we choose how we use our time. And I can't choose for you. And what I did may not work for you. But we have more time than we think we do.
Yeah, I think that thought that time is elastic. I thought that was a very nice statement. I want to ask you about, one of the things that struck me is you've had such a distinguished career, and most people wouldn't know that when you first applied to medical school, and I hope that's okay that I'm going into that,
sure.
that you didn't get into medical school.
I didn't.
You had twice.
Yeah.
What did that teach you, and how has that affected how you deal with setbacks?
Well, it led to what I call the rule of threes, which that was the first time I had to try 3 times, and the third time I got in. And it had a lot to do with the Vietnam War and with it being legal to set quotas on women and so on. But it also had to do with the fact that I did my undergraduate work at MIT. They graded on a curve where the mean was a C, and so my grades were not spectacular. But the rule of how that affected me was that third time, my advisor at MIT told me not to try. So many people told me not to try again. And I just made up my mind. I was just going to try it again. It took me, so I will not name the name of this august surgical organization. I will say it is one of the premier regional surgical associations, not the American, but one of the regionals. I was the first woman elected to membership, but it took me 3 tries. And during that time, I saw others who were younger and who knows, maybe didn't have as good a CV get in. And it was because I was a woman. And the third time that I tried, the people that were writing letters for me wanted to back off. They wanted me to say, okay, let's wait a year or 2. And I'm like, no, I'm going to keep trying until I run out of tries, and they're going to have to shut the door in my face. So that's one aspect of the way it affected me. And I alluded to the rule of threes. The rule of threes is kind of like saying, if I try 3 things and 1 succeeds, that's good. If I try 3 things and I succeed all 3, well, maybe I'm not setting the bar high enough. If I try 3 things and nothing succeeds, then I need to recalibrate. So that's the rule of threes. That's how it affected me. It made me more hard-headed and stubborn than I was even to start with.
Great. Nancy Strand, if you want to actually, I see your question in the chat. If you want to turn on your video and ask the question, I definitely would prefer you asking it than me. And there you go.
Hi. There she is. Hi.
Yes, it's fascinating. I love this story, all of your history. So there are so many specialists now and everything, and I saw some of the chatter about, you know, residents and what 10 years would project, but you have such a valuable, rich breadth of training. What do you think about the specialization now? What would you advise your students and residents?
I think you have to, that's a great question. Thank you, Nancy. I think you have to know yourself. What I tell the students is some people want to know everything about a narrow area. They want to be the best, the very best, the most expert. And some people like to know a little bit about everything. And I'm kind of in the second camp. So first advice is know which you are. And it's right. It's correct. There's specialties in everything: surgical oncology, breast surgery, vascular, minimally invasive surgery, you name it. But there still are two groups of surgeons besides rural general surgeons, who are a wonderful group. But I mean, in academics, there are still two groups of surgeons who are general surgeons. One is the pediatric surgeons. They do everything. They just limit themselves by age. And the other is the trauma acute care surgeons. And if I had to do it over again, if I were finishing medical school and going into residency and wanting an academic career, so that going out into a rural general surgery practice was not an option, then I think I would probably do the acute care surgery trauma route, because I think that's the closest we have right now to general surgery.
Thank you.
I know there's another question from Patrick Nguyen, if you want to, from San Antonio. So I guess you have power in San Antonio right now. Please go ahead.
I do. I want to thank the American College of Surgeons for hosting the Fireside Chat, and Dr. Scott Connor for sharing her experience. I'm a general surgeon in academic practice, 12 years in practice. And my question piggybacks a little bit on Dr. Strand's question, but I wanted to know what are your thoughts on the future of the non-fellowship trained general surgeon? I feel like there's going to be a tremendous demand for all surgeons, but maybe especially for non-fellowship trained general surgeons throughout the community in the US. And so I wanted to know your thoughts on where you see the field going 5, 10, 15 years out.
Well, I don't believe you should have to do a fellowship to be a general surgeon. I'll go out on a limb here and I'll say that we who are training surgeons, it's up to us to help our residents attain what they want to attain. So for example, at the University of Iowa, I always felt, and I think the philosophy continues to this day, we will try to help you do whatever you want to do. If you want to be a high-powered academic, we'll help you get that fellowship, get your research going, spend some years in the lab. If you want to do general surgery and go into a rural environment without a fellowship, we'll help you do that. I think we need all kinds. And I think we should be able to train a general surgeon in 5 years. I think that's plenty of time. I think a couple things have made it a little easier in the academic milieu. First of all, the fact that there's a clinical track at most medical schools, so that if you're a faculty member, you don't necessarily have to publish or perish and get tenure, but you can be a clinically excellent surgeon and teacher without finding that niche. One of the problems with being a general surgeon, and I dealt with this all my life, is I never developed that vertical column of excellence that you really need to do to advance in academics. If you look at my CV, it's all over the map. There's stuff I did when I was taking care of burn patients. There's stuff I wrote when Lab Chole first came out. There's stuff about breast. There's stuff about surgical education. But I think that there is definitely a role for general surgeons. I think there's a tremendous need for general surgeons. And I think that one of the challenges for us as a community of surgeons, in particular, to whatever extent we are all academic surgeons, or mostly academic surgeons, to prepare these people and then to support them when they go out and practice, so that if they have difficulties, we can help them get the skills through the national organizations if they need to expand their practice pattern and so on. Did that answer your question?
You did, thank you. I found that as a general surgeon, I got to pinch hit a little bit as a breast surgeon when our surgical oncology division needed help. I get to be the pop-off valve for benign anal rectal disease when our colorectal surgeons are too full, and I do acute care ER call. So it's actually super fun.
It is super fun, and I think there's no better job than general surgery. I've thought that all my life, and I still think it. But you sound kind of like me, Patrick. You're the kind of guy who likes to know a little bit about everything, and I bet you know more than just a little. You know a lot. You're good at benign anorectal. You're good at breast. You're good enough to pinch hit, and that's the general surgeon. The specialist is the one who wants to know really everything there is to know about that narrow focused area.
Carol, there's one area I want to just maybe emphasize a little bit more and just seek your experience on. Obviously, we're in a time where we talk about issues of diversity and gender and race and so on. And obviously, you are a pioneer from the time that you started in surgery to being a chair in 1995. Tell us a little bit about that experience as being a pioneer from a gender standpoint. What advice do you give to your female mentees and just overall reflections on that?
I'm not sure how to answer that, because it was, as I started telling my story, I had to tell you what a strange time it was in the 60s. It almost seems alien now, and that's a good thing. More doors are open, there are more possibilities. And it seems to me for young women who are starting out now, it's more a question of how do you want to choose to spend your life? What do you want to devote your time to? Mo, I told you when we were planning this talk that I'm not good at talking about work-life balance, because I went very heavy in the work direction. But I've managed to stay married to the same guy. He's wonderful. We met in medical school. We're very happily married. We've done okay. I'm not sure if I answered your question.
No, absolutely. In our conversation, we talked a little bit, and I know I would like to go into the area of your reflections on this past year in the pandemic, but we talked a little bit about well-being, and you talked a little bit about joy. How do we seek joy?
Yeah, I mean, I think, first of all, I think that if you follow your passion if you let your passion determine the way you spend your life, which many of us we're very lucky to be able to do that. Not everybody can choose, but we have the ability to choose the direction that we take with our lives. And if you can follow your passion so that you really, really love what you're doing, so that you get that pleasure out of seeing a patient in the office, sitting with that patient, explaining to the patient what needs to be done, getting their confidence, taking them to the OR, getting them through surgery, and seeing them when they're back to health. If that's your passion, then you're going to find joy in that. If you get to the point where you don't find joy, then it's time to re-examine, retool, think about what you could do. Maybe you need to change. Maybe, we talk about burnout, but I think in the talk I also talked about moral injury, which is, it's akin to burnout, but moral injury is inflicted upon physicians who can't do what they need to do for their patients. And we may see some of this as a result of the pandemic, because one of the questions that was sent in earlier was about the care of cancer patients, and we might want to segue into that. I think maybe that surgeon is here on the
Yes,
on Zoom. But you know, it's the issue of not being able to do what you think needs to be done because the insurance company won't let you, or because your hospital shut down elective surgery because of the pandemic or whatever.
Dr. Fekrad, I see you're on. Did you want to elaborate on that question any further?
Hi, Dr. Connor. How are you doing?
I'm good. Thanks for sending your question in ahead of time. That was very kind.
So I would like to thank Dr. Mohsen Shabahang as well. Salam, امیدوارم که حالتون خوب باشه. I know I'm Persian and he's a senior Persian, so I would like to say hi. Yeah, I asked you about during this pandemic, if you have a case of 2 more patients and you know the timeline and all the whole protocol, what is the best time management to admit a patient? I'm talking about like as a stage 1 to a stage 2 to a stage 3 or a stage 4. How we go through whole process? What is the best way to do? Because you know some they get kind of scaring of the timeline. Some they've been scared to come to the hospital right now. And then what is your advice? What we should do during this whole COVID-19 tragedy?
Well, I think first of all, we need to reassure our patients that they should come in for their routine screening. So if you have a woman with a history of breast cancer, she should come in for her mammograms to whatever extent possible. That was all shut down briefly when the pandemic first started, but most places are now offering those services. I said I was glad that you sent your question in early, and I was glad because I was able to find some stuff on the internet. And first of all, the American College of Surgeons has a document that's available on the internet called COVID-19 Guidelines for Triage of Breast Cancer Patients.
Okay.
And if you have any trouble finding it, just email me and I'll send you the link. And they talk about, you know, things like putting women with estrogen positive disease on anti-estrogen therapy to temporize and so on. Now, the other thing that I found that's more complicated but might be useful as well is ASCO, which is the American Society of Clinical Oncology, has a special report on cancer care delivery during the pandemic. And there may be others out there. But I think the task for us right now, because most places are past the point where we're not closed to the idea of doing elective surgery. And we don't think of cancer surgery as elective surgery, so we can get our patients in to have their surgery. But patients, I think, are not coming in for their preventive care, their checkups, their mammograms.
Yes. Yes.
If they have a little blood in their bowel movement, they're going to ignore it or get some preparation H. I don't know how many screening colonoscopies were done over the last year, but I bet not that many. And we're not going to see the outcome of that for many years. There already have been a couple papers published, and I can't quote them. I was never good at quoting papers, but people have looked at cancer cases as a result of the pandemic. So I think that's something that we can do in our own communities to reassure them that they can come in and get the care they need without being afraid that they're going to get COVID. I think this has been a very hard period. I try to imagine if I were taking care of patients now, I try to imagine sitting with a woman with newly diagnosed breast cancer and her partner or husband isn't in the exam room with her, but is on the phone.
Yes.
How strange is that? Or taking someone to surgery when they couldn't have someone accompany them, you know, and during the strictest period of lockdown, that's the way things were operating. So things are easing up. Hopefully it's going to ease up some more. But if you have trouble finding these, just email me. I'll send you.
Thank you, Dr. Connor.
Jim, you have a question, Star Wars related question for Carol, so I'm going to let you ask that.
Well, thank you very much. I've enjoyed spending this time with everybody for the last 46 minutes, I guess. And she mentioned Star Trek a little bit earlier, but Carol, I thought I'd move on to a Star Wars reference and ask if you haven't had one or more Yodas in your professional career. I certainly have more than one in my own career, which kind of closely parallels your time frame as well. Thank you.
That's a great question. I wanted to talk about mentorship. So thank you for giving me, I would never have gotten where I am without mentorship. And at NYU, it was Frank Cole Spencer and John Ranson and Leon Pachter. And when I got to Huntington, it was my two partners, one of whom took me aside in the hallway of the hospital and said, "You have to get a lab started." And he almost brought me to the verge of tears, but I listened to him and I got my lab going and he helped me and all these things. I've come to I can't even count the number of mentors I've had over my lifetime. And I've come to the conclusion that it's probably not realistic to put the burden of being the mentor on any one person, because you change and they change and the situation changes. I would say if you're looking for mentors, and so particularly for the younger people in the audience, you should be constantly looking for mentors. They don't have to look like you, talk like you, or dress like you. They don't even have to be in the same specialty. Look for people that have done something that you want to do, and then ask them how they did it. So rather than trying to find someone who's going to take you all the way to the top of the mountain, just find somebody who help you up the next couple of steps. And speaking as someone who's been approached and sometimes has been able to mentor, and sometimes I've failed miserably. I mean, I've just absolutely failed as a mentor sometimes. I find I do better if someone comes to me with a specific question. They want to know how to do X, and X is something that I have done. Then I can tell them, this is how I did it. It may work for you.
Excellent. Dr. Miller, are you on? I think you had a question.
Hi, everybody. Hi, Carol. You've had such a remarkable career. It's great to hear about it. You're also so visible in the narrative medicine world, and I was wondering if you could talk about how that came into your life, narrative medicine.
Oh, Pringle, I was hoping somebody would ask that. That's for the last 10 or 15 years, I said, think about, 10-year blocks. So I started to look toward retirement. I thought, I really want to write, and I wanted to write novels. I had this literary ambition, and probably not going to happen, but I started doing everything I could to learn how to write. And what I found is that there's a whole area of medicine called narrative medicine. And it's a branch of the medical humanities. It's mostly being used in medical schools, and it's being used in medical schools all around the country. Basically, the application of story to medical practice, using story to make ethical points, using story to help establish rapport with a patient, using story to decompress after difficult experiences, and so on. So that's how I got into narrative medicine. And I like to go to school, so I went back and I got some additional training. I'm in an online writing program through a small university, Lenore-Rhine. Nobody's ever heard of it. I hadn't heard of it, unless you're from North Carolina, but it's a really good university. And I got my narrative medicine certificate, and I'm doing narrative medicine sessions with the residents, which they tolerate. Hopefully it's okay. We'll see.
Carol, I want to take the prerogative of maybe asking one of the final questions, and then asking you for your final thoughts. And the final question I want to ask is, what is your advice? We have a lot of advice for people starting their career, but we don't talk that much about how to end your career. What advice do you have for that?
Again, 5-year horizon. And actually, I find a lot of people are asking me that. Clinicians in other departments that I've known over the years that we've shared patients with, that's what they want to know. They're thinking about retiring. How do you do it? I was lucky. I was able to decelerate. I went part-time. That was a program through the University of Iowa. If you can do that, it makes it easy. And you think, well, surgeons can't work part-time. You're going to work full-time and you're going to get paid half-time. But you can do it. You just limit the days. You say, I'll be there for clinic this day. I'll be in the OR this day. And I'm not coming in on these days. So if you can decelerate, that helps. It helps to have a house that's big enough that there's an area for you and a different area for your spouse. A space is good. I think we're all learning that during the pandemic. Having adequate space to spread out is really good. And developing another interest, whatever that might be. I mean, I know surgeons that have started vineyards. I know surgeons that have taken up woodworking and music and things that you could not take up. One of the great things that's happened with the pandemic is that online education has just blossomed. And you can literally take courses in almost anything you might want to learn to do. So that's my advice. But I think you have to have a plan. I think that the problem is, for many of us, our identity is so tied in with what we do as a surgeon. And that's fine, that's good. That's part of the joy of being a surgeon. But you're more than just a surgeon. You're more than just a job. And if you retire in your 70s, I was 69 when I retired. But if you retire in your 70s, which is late, but not that old for a surgeon, you could have another 20 years, healthy, college-educated person, you'd have another 20 years. That's a whole nother time to do things. And I think I would get bored just going out and playing tennis or shoveling snow or whatever.
It sounds like you still interface with residents at this moment.
I mostly interface with med students at this point. I haven't worked out the thing with the residents to my satisfaction, but I'm trying to get as involved as I can. It's actually easier now that I can do it over Zoom because I can come to the conferences more easily.
So I just wanted to point out a comment that's made. I really hope I end up with a residency director or mentor like Dr. Connor. So that's the inspiration. Any final thoughts, Carol, as to leave us with any advice or any final thoughts?
Well, I would say, be of good cheer. And this is a great time to be a doctor. This is a great time to be a surgeon. It's a wonderful time to be a general surgeon or to be a surgical specialist. You have skills that no one else can duplicate. Just be of good cheer, enjoy it. Be prepared for the fact that many of the operations you learn to do in residency, you won't do after a couple of years. Just be prepared to learn the new things and to go with the flow. Someone says, do you have any advice for a
medical student who would like a strong impression during their surgery clerkship?
Like to leave a strong impression, I assume you mean? Just be willing to jump and do whatever needs to be done. No job is too small. Deal with the stinky wound, change the leg ulcer, go see the patient at the end of the day that nobody wants to see. Sit down and take time with the patient that can't give you a good history because they just can't for whatever reason. And just do that. Extend yourself into the team and make yourself such an invaluable part of the team that they say, I can't imagine getting along without so-and-so when you rotate off.
Well, Carol, I have to say, clearly from the comments in the chat box, you've been an inspiration. I see one of our medical students has summarized all the high points of tonight, and so I welcome people to look at that. I want to thank you so much for spending the time with us. I've had the honor of actually having a preparatory talk beforehand, and really enjoyed that, and was very much looking forward to tonight. I want to ask all of our participants to take a look at the evaluation, and please fill out the evaluation. With that said, Dr. Sachdeva, I'm going to yield the floor to you for any final thoughts.
Thank you very much, Dr. Shabahang, and I would like to add my thanks as well to Dr. Scott Connor for a fantastic evening. Your words clearly have been inspirational, as you can see in the chat. And also, we have all benefited from your wisdom. I want to also add two other thoughts. I think the hallmarks of a leader, as many of us know, are to be authentic. And you've clearly demonstrated that this evening, and to tell stories. And the power of storytelling is second to none. And again, you've demonstrated that so very well this evening. So thanks for being here. Thanks for inspiring all of us. And thank you all for attending. Have a great evening.
Great. Thank you all very much.
Thank you.